Hi everyone, thanks for listening to my presentations. Today I'll be talking about adrenal insufficiency, but I'll be limiting myself to the treatment only. And this will form part 6 of 7 when it comes to the series on adrenal insufficiency. If you haven't listened to parts 1, 2, 3, 4, 5, please do. With that, let's go. If you have followed this series from the beginning, it will need no more introduction that we're dealing with neuroendocrine disorder when it comes to adrenal insufficiency. And specifically, we've been battling with hypothalamic pituitary adrenal axis. This is just a reminder, so we know what we're treating, okay? Okay, part of the recap is to remind ourselves about tertiary adrenal failure, meaning that the problem is at the level of the hypothalamus. And with that, corticotropic releasing hormone secretion will be impaired. And no enough signal will get to the pituitary gland, no enough ACTH, and by the time the impulse will reach the adrenal gland, there'll be no enough, and then there'll be cortisol deficiency. In secondary adrenal failure, the problem will be at the level of pituitary gland. And that means the problem is with the corticotropin, that is ACTH. And when that is the case, no enough impulse going to the adrenal gland, and cortisol deficiency will be the picture. Lastly, as part of the recap, the primary adrenal insufficiency is otherwise known as Addisons Disease or adrenocorticoid disease. Could be mineralocorticoid deficiency and cortisol deficiency. Mineralocorticoid deficiency is due to renin-angiotensin system impairment, which is not controlled by the hypothalamus or the pituitary gland. Therefore, no problem with the aldosterone. Crisis. In Addisonian crisis, the problem will be sudden. Why that? Because there will be sudden drop in adrenal function. And mostly, this will occur in primary adrenal gland. Okay? Can also be present in hypothalamic or pituitary problems, but mostly in primary adrenal insufficiency. It is a life-threatening situation. So when you hear the diagnosis that this individual is having Addisonian crisis, it means we have to be on the run immediately. Okay, as per the treatment, just a quick reminder of what we are all familiar with, that whether the patient has come in coma or not, we have to check the airway first, that is the nostrils, the air orifices, and the mouth to find out whether we have foreign body or secretions, and then remove as it may be appropriate. In other words, we have to check for the patency of the airways. Then B, for breathing, at that level, we'll be checking for what the O2 sat is. If it's low, we give oxygen. What is the respiratory rate? And then we'll check for central or peripheral cyanosis. Any tracheal deviation or not, then we have to observe for chest and abdomen movement with respiration. And we move on to auscultate for any abnormal breathing sounds. And of course, we percuss for hyperresonancy or dullness. Then we move to C, which will be circulatory system. At this point, we will call for the vital signs. What is the blood pressure? Remember, it's likely we'll be dealing with hypotension right now. What's the heart rate? The heart sounds, what are we getting? Any murmur somewhere, any abnormal heart sound somewhere. Then features of the hydration, any sunken eyes or skin toggle. We have to check that. Then immediately we set 2 lines, one for generous IV fluid and the other one to take samples for investigations. We must call all necessary units immediately. Consult to endocrinologist, and as the case may warrant, we can invite others like anesthesiologists in case we need endotracheal intubation and the attending physician will not be able to do that. Then we'll need anesthesiologist at that point. Then we head to lab. When the lab people have come and they've taken the sample. On getting to the lab, what are we going to do? Next slide. Okay, ACTH stimulation test, generous IV fluid, but watch out for complications here, please. Then hydrocortisone. We have to give this at the rate of 100 milligram intravenously start. Then hydrocortisone at the rate of 50 milligram intravenously every 6 hours for 24 hours. Or if you don't have hydrocortisone around, you can make use of dexamethasone. And if that is not available, you can also use prednisolone. So hydrocortisone or dexamethasone or prednisolone we have to administer at this point. At the lab, we want to know the value of renin, procalcitonin, because that will guide us as per whether we have problem with bacteria or virus and whether our medication is working or not. Aldosterone level, ACTH level, glucose, electrolytes, plasma cortisol level, renal function test, thyroid function test, blood and urine culture. Okay, still on treatment. If the lab is revealing that we have hypoglycemia, we'll give glucose intravenously. We have to keep an eye on the blood pressure because we'll be dealing with hypotension here. After immediate resuscitation, we have to maintain the IV fluid until the individual will be able to take per oral and retain. And we will look for and treat all reversible causes. For example, infection. Still on treatment, we have to make a definitive diagnosis because we should know whether we are dealing with primary, secondary, or tertiary adrenal insufficiency. So we will change to per oral glucocorticoids from the IV route, since the individual is now out of coma or whatever the first presentation is all about, and the individual could take per oral and could retain, stop intravenous glucocorticoids. We switch over to per oral. But we will never stop glucocorticoids suddenly. We'll have to tail off the steroids later on. In mineralocorticoid failure, then we will use fludrocortisone. You could see that highlighting that boldly. Fludrocortisone is life-saving in mineralocorticoid failure in Addisons disease. And we'll give that at dose of 0.1 milligram per hour once daily after we have stopped the intravenous infusion. We will correct hyponatremia using sodium chloride tabs, and we'll correct hyperkalemia based on the level of potassium. I repeat, hyperkalemia will be corrected based on the level of potassium. You can check my channel for full presentation on hyperkalemia, but briefly, if the level is 6.5 millimoles per liter and above, of course, we'll grab our glucose, our insulin, our salbutamol, our calcium gluconate, and everything will rush it to bring it down. But if the level is just like 3.8 to 4.5, we can just counsel against ingestion of food rich in potassium and keep our resin as carefully somewhere. Okay, so that will be enough at that level. So it depends on the level of potassium. Still on treatment, we can correct hyperkalemia with IV fluid and calcitonin. Okay, We have to repeat electrolyte frequently because resuscitation may correct some particular problem like cortisol and volume replacement with normal saline can correct hyponatremia. That is why post-resuscitation, we have to repeat electrolyte. After resuscitation, you've corrected the cortisol and volume with normal saline, the level of sodium will likely rise at that time. We have to counsel against stress because the major cause of Addisonian crisis in people with Addisons disease is stress. And of course, autoimmune and the rest. You can check my channel for causes of adrenal insufficiency. Don't abruptly stop steroid or glucocorticoids. We have to counsel against that. Why? Because the patient might be discharged home on glucocorticoids, but some people, for some reasons, may suddenly stop the medication they are placed upon. If that is the case in anyone with Addisonian crisis, then there will be more crisis. Now, lastly on treatment, we have to get EKG. Why that? We want to know what is happening with electrical activities within the heart. And that will be as a result of probability of calcium and potassium. So, in the face of hyperkalemia, get EKG. Cortisol deficiency can lead to syndrome of inappropriate antidiuretic hormone. You should have that at the back of your mind. We have to establish the cause of this problem. We must get definitive diagnosis using history, physical examination, ACTH stimulation test, laboratory investigation, radiological investigation if you are suspecting hemorrhagic infarction of the adrenal gland. And that wise, CT will be appropriate. We will discharge to family physician. As a matter of fact, you can check my channel for diagnosis of adrenal insufficiency. I have two. One published completely on ACTH stimulation test only, and the other one on other procedures to have a definitive diagnosis of adrenal insufficiency. And it will be advisable that the affected individual should wear bracelets indicating I am a known individual with Addisons disease, and that will guide when they see any health official or paramedics in face of crisis. And with that, I've come to the end of this very presentation. There will be more about how to handle adrenal problems, Addisonian crisis, and how to live healthy life, obeying the necessary instructions. So watch out for my next presentation that will be on 40 ways to prevent Addisonian crisis. Thanks for listening. Please remember to share, remember to subscribe. I appreciate it.